So thank you, Joel. My job here is to try to avoid provoking any questions or curiosity from Dr. Mata and staying clear of him today. So I'm going to talk about incision approaches and wound management. This is a good segue for Masonics and the next one. These are my conflicts. I don't think they're relevant to this talk. So I think most of us have been in this situation. You see a patient 2 weeks post-op, and everything looks good. And then at 4 weeks, you get this call that the wound is starting to break down a little bit. And everybody that's been doing DA for quite some time have seen this not infrequently. If you look at the data, the complication rate of wounds in anterior approach is higher than in posterior approach, 1.4% versus 2% versus 0.2%. And this held true after their learning curve. In this study that looked at 36 articles over 11,000 hips, the overall wound complication was 1.2%. And this is a paper out of the Mayo Group that's getting published this year. They had a 2.7 wound dehiscence rate requiring some sort of intervention. And just like my observation, the average time of diagnosis was 27 days for 4 weeks. Luckily, they were all superficial, and there was no difference in survivorship of 5 years in their paper. What are the risk factors for wound complications in anterior approach? The guys from New York have a pretty good paper on this. They saw an 11.5 wound complication rate requiring some sort of intervention, whether local, in the office, or surgical intervention. And they found that BMI and diabetes were independent risk factors. And they calculated the odds ratio of those independent risk factors and combined. And if your BMI was over 40, the odds ratio of having a wound complication was 9.7. If your BMI was over 40 with diabetes, it was almost 12, the odds ratio. So you can see either combined or independent, those are risk factors. And we know that the original description of the direct anterior approach is the longitudinal incision, like most of us do. Now, there's this concept of the main folding lines or crease lines in the body. And why is this important? Because the collagen fibers run parallel to these crease lines. So you can imagine if you make an incision parallel to those collagen fibers, there's going to be less tension on the wound versus if you do it perpendicular to those crease lines. So this is a wound which healed under a lot of tension. You can see it's hypertrophic wound that here with like a keloid. So it would only make sense that if you make the incision parallel to the crease line, which like you see here, the wound will heal in less tension, and therefore you would have less complications of wound healing. The crease line incision or the bikini incision basically is a third medial to the ASIS and 2/3 lateral to the ASIS, and this, you can see both of them there. This was first described by Lewinick in 2013, and he published his first paper, and what he found was that patients that had the crease incision had shorter, narrower scars, and there was a better patient satisfaction rate with that incision. The overall rate of peri-incisional numbness was kind of similar in both longitudinal or the bikini incision. But, you know, if you look at the paper, the average BMI of those patients was 25. I don't get a lot of those patients in my office, so kudos to them. So what about this paper from the Rothman Clinic? They matched 86 bikini incisions to 230 conventional incisions. And they found less incidence of wound issues in the bikini incision, however, not statistically significant. But on the patients with a BMI over 30, there was no complications on the wound on the high BMI, on the bikini incision versus 16% on the conventional incision with this small number of patients. And this is the only prospective randomized clinical trial, level 1, looking at this longitudinal versus crease incision. And they just found improved scar appearance in the bikini incision, no other difference in functional outcomes or wound complications. But then again, average BMI 24. So we're talking about small patients in this study. And then there's the issue of the lateral femoral cutaneous nerve. This is Lee Rubin's work where he described the different anatomy of the lateral femoral cutaneous nerve. You have the sartorius, the posterior, and the fan type. And the concept is that with the crease incision, you're going to go across a larger area where the nerve is going to be. Therefore, there could be a higher incidence of lateral femoral cutaneous nerve injury. And this is out of the Cook's paper where he referenced 2 prospective randomized trials looking at lateral femoral cutaneous nerve injury, Bikini versus longitudinal incision, and the incidence of symptoms of the lateral femoral cutaneous nerve was higher on the Bikini incision than in the longitudinal incision. It appears that that resolves over time, and after 6 to 12 months, they're both at the same spot, but at least initially, there's a higher incidence of those issues. So in terms of the Bikini and longitudinal, if you read at the data as I read it, I think, there's favorable wound complication data for the Bikini. There's limited data on higher BMI patients. There's a potentially higher lateral femoral cutaneous nerve injury, and it's not as extensile, so it's really not recommended for the novice surgeon. What about wound vacs or negative wound pressure therapy? We know that at least in revision total hip arthroplasty, there's less incidence of surgical site infection with wound vacs. Now, what about in the DA specifically? This is the only prospective randomized trial looking at this, and they looked at only high-risk patients, BMI over 30, diabetics, previous surgery, and smoker. They put a wound vac for 1 week, and they found statistically significant lower incidence of surgical site infection and surgical site complications with the wound vac. What about this ring retractor? You've seen a couple pictures of this. We had a paper on this about 10 years ago. We used to put it underneath the skin. Now it goes under the tensor and the rectus. And we did a prospective randomized trial. We took pictures at 2, 6, and 12 weeks. And we had 2 independent plastic surgeons rate them with some specific scoring system. And the scores were the same. There were no difference in complication rate, so we kind of abandoned the use of that. And what about atrophy of the lateral femoral cutaneous nerve? I bet you that if you look at this, it's higher than you expect. And this is because the innervation of the tensor goes on the medial side of the tensor, and the place where it inserts in the muscle is variable. So if you're overzealous, coagulating the lateral femoral cutaneous vessels and go too medial in it, you can denervate the tensor, and that's a big dissatisfier for patients. So in conclusion, the DA approach has been associated with a higher wound complication rate. I think the data is there to support that. I think the Bikini incision decreases wound complications, but it could increase the incidence of lateral femoral cutaneous nerve symptoms. It's less extensile, and more data is needed on higher BMI patients. I think wound vacs may decrease the risk of wound complications and surgical site infections in high-risk patients. Thank you very much.